We heard a little bit about, I guess, the Herculean task that you had in front of you, but I'd be curious to sort of start with a little bit more detail about, what you had to go through. In particular, I'd be curious sort of who it was that was getting the face transplant, why they needed a face transplant, and who donated the face and things like that.
Sure, it's a pretty lengthy process. It ties in a lot of factors. So the individual that we, as a team, decided would be the candidate for this operation was a young man who I'd known since 2005. And he came to me with severe facial disfigurement, had undergone multiple surgical procedures, of which really none of them had restored him to what we consider normalcy. He wore a mask, wore a baseball cap, barely you could see his eyes. So at that point, just to give you a little bit of reference in history, the first face transplant in history occurred in 2005. This is the time that I had met Richard Lee Norris, and at this point we really didn't understand facial transplantation, so we decided to proceed with conventional surgery. So we fast forward the clock. I had been performing surgery on him for a number of years. At this point, there are a lot of things going on, and several important sentinel events. Number one, we were involved in a war in Iraq and Afghanistan. So I was fortunate enough to be taking care of wounded warriors, but also fortunate enough to be part of an Office of Naval Research grant, which was part of the wartime protection program to care for wounded warriors after they were coming back from the battlefield. Our research seemed to be pretty profitable from a scientific standpoint, and after working on Richard for a number of years, we felt that we had reached the end of the road of what we could provide with conventional surgery. Despite the most elegant plastic and reconstructive surgical procedures, there was really no way to make him normal. After a very lengthy regulatory process, he signed on to a consent to proceed with facial transplantation. And facial transplantation, by definition, means that we are removing the face that he's had, although it's not a normal appearing face, but a face as he's known for a large number of years, with great risks, of which the patients do understand. It is a human subjects research trial, so it's not a guarantee, but there's a very lengthy process. And if everything works well, he will receive the face from another individual. This individual is a brain-dead donor, an individual whose family consents not only for organs, but also for the face.
So, I mean, I think there's a lot of interesting questions around sort of your sense of self, and right? And is this something that you have to screen, sort of the mental well-being of somebody before you give them somebody else's face?
There's a lot with the question, Tim, and there's a lot to think about, and it's interesting as even lay people, because before I had done this transplant, before our team got involved, we have a lot of questions about facial identity. Who is this person going to be? Now, I could only speak from experience of one patient, and I've had the opportunity to visit a lot of the surgeons throughout the world and see their patients. But what we know, having done one now and seeing our experience with our patients, that this concept of facial identity that we would see could be a problem is not really the case. When you have someone with severe facial disfigurement, I really feel that they do not see themselves as self. So when they look in the mirror, they do not see what is normal. And it took me quite a long time to figure that out. So their face is not normal. When they receive a new face, one that appears normal, it's the first time that they really identify themselves as a normal appearing individual. Now, having said that, when you transplant the face from one person to the other, I will tell you that there are some features that remain from the donor individual, but when you bring them together to a recipient face, the faces are almost a blend of two individuals. So it's not as if you are going to see a donor walking through the street and you would recognize that individual as a donor.
So, I mean, how long does it take somebody who's had a face transplant to begin to recognize their new face as their own and identify self?
Sure. So in Richard's case, after we had completed this operation, we waited for about 48 hours, and although I knew that he looked very normal, as a surgeon, especially working on the face, you're always concerned about what is the perception of self for an individual. I may think that this person looks normal, but we always wonder, what do they think is normal? And at that point, I gave him a mirror, and I prepared him for this moment to say, I really want you to look at yourself in the face. Now, we had a lot of family support, very nerve-wracking moment because we really don't know what his perception or how he's going to define that. And he looked in the mirror, and I will tell you, it was a very emotional moment in that room at that time. And he looked in the mirror, and obviously he realized that for the first time in a long time he was normal. And he embraced me, and obviously it was a pretty emotional moment in there.
Yeah, I can only imagine. I mean, I guess to bring it back to the surgery a little bit more, 36 hours, 150 surgeons working with you, that's a sort of monumental task to undertake. And I guess my question is really going to have two parts. I mean, one is this idea of how are you going to maintain not only your own awareness and attention and sort of task-driven, goal-oriented behavior over 36 hours, but how do you maintain a team? And then on the flip side, there's also, I presume, a ton of planning that goes into it. So I guess to start with the first, I mean, like, do you do preparations to?
Of course. So when we think about surgical training, at least the way we're trained to endure a large number of hours. I had never really trained for a 36 operation. How do you prepare for this? But we took it on in a very regimented task. So we practiced on cadavers. We created a cadaver that we defined as a donor and a cadaver that we defined as a recipient. And we did the entire operation as if it were occurring in the operating room. We did about 15 rehearsals like that, very regimented. And I will tell you that every moment is serious as if we are going to execute this surgical procedure. You have to keep in mind nothing of this magnitude had ever occurred. So there's a great weight on my shoulders, on my team's shoulder, but as a lead surgeon, it's essentially on me. There was a great amount of concern from the surgical community that our team may have been too small, that our surgeons were too young. Could we handle the complications? Always a tremendous amount of obstacles. So the only way that I thought that we could limit the obstacles was just to exercise and train. We did this about 15 times. We identified issues, we would refine them, but the reality is that when you work on a cadaver, there's no way that you could ever translate that to a human intervention. An important event which took place between the cadavers and the actual clinical transplant is what we define as a research procurement. For lack of a better word, it's a dress rehearsal. So we ask another family, and through their generosity, they give us the opportunity to procure a face. In other words, to perform the facial dissection without transferring that face to another individual. Because we want to make sure that if we're going to commit to the surgery, that all the tissues will be alive. Because we're going to include the entire face, the eyelids, the nose, the lips, all of the bones, the teeth, the tongue, the nerves, and nothing of this magnitude had been performed. So before I could commit Richard to that, we had to practice on a brain-dead donor who had already, family had consented to organ donation. So because of that individual, we were able to confirm that now this was a technical reality, this could occur. So that pivotal moment allowed us to move forward, and I was really convinced that now it was going to be possible.
Yeah, I mean, I think this is interesting from a neuroscience perspective because, we all know that, practice makes perfect. This is the old adage. And I think it's, and we all have experienced that. You practice some skill and over time you get better. And I think that in particular, something like this at 15 is a huge number of practice surgeries to undergo. I mean, were they all 36 hours?
No.
Okay.
I would say that most of the surgical procedures were about 12 hours. So there's training.
So do you break it down into pieces? I mean, so, I would imagine, okay, you need to deconstruct this very complicated.
100%.
Yeah. And so how do you go about doing that?
So things to think about. I'm going to give you facial transplant 101. So a couple of things that we have to keep in mind. We have a donor who is brain dead. We are keeping this patient supported artificially so that we can procure organs while they are being perfused. That patient is in periods of stability and instability. For lack of a better word, that patient wants to leave the physical material world, so we have to support that patient. In the meantime, we have an operation going on in the recipient. So we're reaching points in the donor and the recipient. The recipient we have to be very careful with, because we have to go reaching points that we feel are getting closer to irreversibility. So we cannot remove the entire face, because if we, for some reason or another, lose the donor because of instability, we've already removed the face. So we do this in a stepwise fashion. That's probably the most challenging time, when we reach that point. And for me, it was the most nerve-wracking when we had already procured the face. It's still being kept perfused, but now we have to go into the other room, and I have my team dissecting the face. Very challenging, because this patient's had a lot of surgeries. And I think going into that face, you have to consider yourself as individuals going into an archaeological site and almost dusting off little bones to identify nerves, all these vital structures that we have to reconnect to ensure that they work. And these nerves are barely a millimeter, very thin little white cords, and the nerves are the most important. That's what gives you the ability for sensation and facial expression. But we reach a point that it's the point of no return, where we remove this face that Richard has known, he's had for 15 years, it comes off. Now we have to ensure that it's time to transfer this, and then will it work? Mm-hmm. So there are multiple steps, but when you think about 36 hours, although we had trained 15 times 12-hour operations, we never really trained for 36 hours, but it's pretty simple. You know, we're trained to do this, and I will tell you, when you have this amount of responsibility on your shoulders, the last thing on your mind is to get some sleep or get some rest. But we're a small team, and we know exactly which piece has to be done, and we're interchangeable enough, but we're able to get to the end point. We don't rest until that end point is there.
So all people were awake for 36 hours?
36 hours.
Wow.
That's correct. But it doesn't end there, because when 36 hours ends, you have to consider that when a patient gets a transplant, back to the Transplant 101, that patient has to be on medication for life. Our skin is one of the most complicated organs. It's our barrier to the world. Because of that, it doesn't handle antigens very well. So when we transfer a face from one individual to the other, we're transferring skin, and it has a lot of antigenic antibody elements, so they really want to fight. So we have to give this patient a lot of immune suppressive medication, which are anti-rejection medications. And a patient can go through a pretty aggressive rejection episode. So once you transfer the face and the blood starts going into the face, you do feel a bit of improvement. Now you're feeling like the face is perfusing, but now in the back of your head and back of my head, I'm thinking, when's the first rejection episode going to come, and how do you keep this going? So you get the patient to the recovery room. Now in your mind, you're just wondering, when's it going to come? What's it going to look like? So you're not really resting. Mm-hmm. You know, you get a couple of hours of sleep, but you're just on constant alert. When's that going to come? How's it going to look like? And what's my plan of attack to overcome it?
Yeah, I mean, again, I think from like a neuroscience perspective, the thing that's really striking to me is that you have this incredibly complex task, and you obviously have a goal that is out in front of you, right? And we all have goals. And pretty much that's how we move through our lives, is we are always constantly trying to achieve our goals. And as I'm sure most people are intimately aware, we are very poor at achieving our goals, right? We are not very good at planning. We're not very good at making sure that every step along the way we are sort of moving towards our goals. And in fact, there's going to be often times where to get and to achieve a goal, you have to sort of move in a way that is maybe not directly towards your goal, but sort of moving in a more circuitous path. And so, you know, I think this is one of these interesting questions to me as a neuroscientist has always been, well, if we have a complex end goal that we want to reach, and we've learned some basic individual steps, right? So in your case, I would assume, you know, you go through residency and you're learning how to, you know, do some hidden stitch or something. And then as you move up, you learn to do more complicated things. And so this question of how the brain sort of evolves and can use very simple rule representations, very simple task representations to sort of form the basis for more complex ones is actually a question that I've been very interested in. And so I'm wondering, as you sit down and you probably have a a list of steps that's thousands of items long. What sort of structure do you put into this task, right? I mean, is it a hierarchical structure? You say, okay, my end goal is to obviously move somebody's face from person A to person B. You know, is it linear so that every step before that you have it written out, or is it sort of more like we define subtasks? We say, okay, the first thing is to remove a face, and then how do we do that? Well, to remove a face, we have to, do X, Y, or Z. I'm just interested in how you structure these things.
Yeah, so there are a lot of, it's a great question, and I'm going to try to simplify it for you. A couple things. Number one, from our standpoint as surgeons, we're trained well. I would say that I did not have a plan. If someone were to ask me 10 years ago, I'm going to do a face transplant, I'd tell them they're crazy. What are they talking about? Because I began my life as a dentist. I don't know what, I made a wrong turn somewhere.
Well, your hands look pretty big to be a dentist.
I really thought that my motto was drill, fill, and bill. I thought I was going back to Miami to be a dentist. But as I went down this path and I became a dentist, and then I went into oral surgery training, and I think the same question always was in my mind. I always wanted to, I saw a problem that was unsolvable, and I felt that if I just got a little bit more training, I could solve it. And then I became an oral surgeon, and that wasn't enough. And then I proceeded to go into general surgery. And the challenging thing is when you start getting all this education, and I've seen it in a number of people that are very bright, they go down this path, and then you can sort of get lost in this world of really defining who you are. But everything came together pretty nicely, and I went into general surgery at Johns Hopkins, and then I did my plastic surgery at Johns Hopkins. And there was one piece that I needed, and here, sort of being in a place of Asian studies, I proceeded and lived in Taiwan, where I learned microsurgery from probably one of the pioneers in microsurgery in the world, and I was very fortunate to be a part of that. But if you
so
put
how
all
long
this,
total training? I'm just curious.
What's that?
How long was your total training?
Let's see, dental school, if you want to exclude, well, college is 4, dental school is 4, oral surgery is 5, medical school 2, general surgery 2, plastic surgery 2, microsurgery 1. So it takes people like myself 23. A little bit longer.
Yeah.
So, but anyhow, in the back of my mind, as I saw facial disfigurement, especially when I started seeing the soldiers, I felt that there was something that we had to do better for them. And as I had the opportunity to see the face transplant patients throughout the world, I wondered, do they really understand, number one, what it is to get a face transplant? So when you sign this consent, do you really think people understand what they're going to get when we don't even know how this field is going to come about? Number two, when they receive this face and they look in the mirror, do they see themselves as normal? Number three, they're on medication for life, so this is pretty much it. We haven't really gotten into the world of, I received a face transplant, I didn't like it, I'm going to go ahead and change and get a new face. That's leagues ahead. So I felt that I really had a moral and ethical obligation. If I'm going to take on this charge and I wanted to do it at the level that I felt would be right, we have to do all this training. So going back to your question as far as recipe. As a matter of fact, tonight I was putting down the recipe for the transplant that we're preparing to do here in New York. And as I was thinking about every step is very methodical. It's very well thought out. I don't move on to the next step until I know what's going on in the other room. So every step is built on the other. But as we go building on those steps, we start getting into increased level of complication, of which we reach the point of no return. Everything is practice, everything is rehearsed, and every time we practice that, we go defining a new obstacle and we try to make it even better. And I think as we look at this whole new field and we try to define it, that is the only way that this can be done, because the face is very different than every other organ. We can't, if the kidney doesn't work, you can get relisted and get another organ. You can, but with the face, it's a more complicated procedure. And we're trying to define even how we even study candidates to be listed for patients as patients for face transplants. So big issues that come into play are compliance. These patients really understand that you have to take medication for the rest of your life. Most of these patients are young, enthusiastic, motivated. Do they really know what that means? Number two, if we provide this gift for them, how do we know they're going to take care of this? So we do a lot of field work, and we're going to travel now to go see our patients, see the support system in their home. Do they have medical support? Do they have family support? Do they have society support? Do they have support from spiritual? So all these things have to come into play because we're starting this whole new field, and a lot of it requires field work from a big psychosocial team, which is a great component of my team here at NYU, and I'm very fortunate to have them, to really understand every level from an ethical standpoint, from a psychological standpoint, from a societal standpoint, and how long will this last? Keep in mind that the first transplant occurred in 2005. So we have limited data how long these face transplants will live for.
And is it still, in 2005, it's still?
Yeah, so Isabelle Denoir is still doing well. She is French. She likes her wine and she likes her cigarettes. And it's coming along pretty well. So there really haven't been any major events. There have been 30 face transplants that have occurred throughout the world. I have close contact with all of these teams. There have been 2 deaths. The deaths have not occurred immediately from the surgical procedure. They've occurred related to other complications. Most of the complications, I would say, are tied into patient selection. So we have a responsibility to choosing the right patient that we know will take the medications, and if there are any issues, they're going to report to us right away. Which brings in another element of now individuals and groups want to perform face transplants on blind patients. I do a lot of facial reconstruction on blind patients. I don't have a feeling against it, but I think when we're talking about facial transplantation, part of the process is identifying rejection. So you have to be able to look at it. There's a change in the quality of the skin. You see redness or you see swelling. So, you know, a blind person may feel but may not be able to identify rejection when it's early enough that we can treat it and reverse it.
Yeah, I mean, it strikes me as sort of a tough question in terms of the moral impetus to, do a face transplant, right? I mean, I presume that many of the recipients aren't in mortal danger. There's no medical reason, so this is almost purely a cosmetic.
If you want, yes, I would consider it. Most people consider it cosmetic, but cosmetic's not the right word. This is a quality of life issue.
Right. It's a psychological.
Liver transplants are a quality of life issue. Breast reconstruction following mastectomy is a quality of life issue. So that affects the quantity of your life.
Right.
And how you're going to pursue that quantity of your life.
So what is the quality of life of somebody who receives a transplant? Face transplant?
So from Richard's standpoint and looking at what's happening in the world, these patients leave the home, they leave the cave, if you want to call it that, and they get out, and they get jobs, and they go to school, and they get a significant other, and they're liberated. So their life changes dramatically. And that's been wonderful to watch. And even in Richard's case, just communicating, if he were walking in this room, he'd stop and say hello. It would take him 20 minutes to get here. Because where before, you know, he would just sit in the back, he'd go to the darkest corner.
Sure.
And just to see that is remarkable. But I still recognize that there's a huge amount of psychological scarring that exists behind this great face. He's lived with the deformity for a large number of years, and that does not go away in an instant. And so as I think about the problem with the wounded warriors, and unfortunately it's very sad to say, wars are not going to end. Attacks are not going to stop. Our homeland's going to be compromised. So as I think about the big picture, I think about full facial burns. And what do we do with these patients? I think about pediatric patients. Very complicated issue. Should we be responsible as parents to prevent a child from getting a face transplant because of the informed consent process? Should we let that child become an adult? And as I include much smarter people and myself and my team addressing the child psychiatric issues, children that live with severe facial disfigurement until they become an adult, they really live a complicated life. So all these questions come to mind, but I feel that we have to answer this, we have to study this correctly, and make sure we're moving in the right direction. So going back to your 36 hours, when does the worrying end? It never ends.
Yeah.
Every time we do one of these, I inherit more issues. People say, why isn't my hair gray? I go, you have to have hair to turn gray. I have very little, and that's what happens.
So yeah, I mean, I guess it's an interesting question on whether or not there's self-selection for surgeons who are able to maintain this sort of vigilance over 36, or is it something that you feel could be trained? And I guess related to that, I'm interested in your sort of viewpoint on cognitive enhancement in general. So we all use drugs to enhance our cognition. If we're drinking coffee, then
Sure.
it has caffeine. If you're smoking, you're getting nicotine. And the reason for this is to sort of enhance your cognitive capability. So I'm curious, whether or not, A, you think there's some genetic component to being a good surgeon, whether or not it's trainable, and whether or not you sort of use different mechanisms to sort of facilitate.
There's no question it requires a skill set. It requires a skill set. I think it requires some intestinal fortitude. We call it courage. It also requires some ambition to help solve a human problem. You have to be passionate about it. I think passion is a large house, and it houses all these things because you want to be better. And a lot of these things can be trained. Some people are born with these elements, and being a leader in this field and seeking out talent, individuals that I want to train, you see the skill set. They don't all come with it perfectly, but you can home in and sharpen them, and I try to build on everyone's strengths. We all have weaknesses. I have weaknesses, but we try to overcome the weaknesses with the strengths. But there are some things that are inborn.
So is there anything that you do that you feel like enhances your ability to maintain vigilance?
Well, I like the arts. There are things I like, photography. When I talk to you here and I'm looking at your face as I do with a patient, sometimes I see different things than when I take a picture. And I take a photograph and I study that photograph until I can't even see it anymore. And then I take this photograph and I mark on these photographs and I do all my marks as I think the operation should go. So maybe that part of artistic nature, creativity ties into this in drawing and just thinking about a problem. And it's I don't know that there's any recipe for this.
So this has been a sort of a big push, at least in neuroscience recently, and this idea of brain training, right? So there's a lot of brain games that have been created, and most of them don't do anything, right? They will teach you how to play that game, and you'll get better at the game. But they, as far as the research is right now, have very little sort of extension beyond the game, right? And so I think this is an interesting question about whether or not this is something that's innate, or whether or not it really can be something that is trainable. And I think what can be trainable, right, is that you can use different heuristics or approaches, right? So you can learn a correct way to approach a problem, right? So if you're looking at dissecting a photograph, that's teaching you how to perhaps think about dissecting spatial configurations or something, right? And I think that this is, maybe there will be, you can learn how to use the resources that you have, right, in just better ways, right? I think, so I'm sitting here and I'm thinking about, okay, I'm faced with taking somebody's face off and moving it onto somebody else. This is just, it's just, you wouldn't know where to begin, right? And so I think it's interesting to me to think about, like I said, try to dissect these problems. And one thing in particular that is interesting is that you have so many things that you need to keep in mind at any point in time.
Sure.
Right? So you're probably juggling dozens of different factors, and you're I'm sure patient variables as well as sort of what your goals are, how the surgery is going. And the reality is that we don't really have the capability to monitor or even see more than about 4 things at any point in time. And so there's this really strong cognitive capacity where you just can't do much, right? This is commonly, I think, seen when you're sort of driving down the road. This is why they tell you don't pick up your phone and text, is because you don't have the capacity to do both things at the same time. So, this question of how you make use of your capacity is really interesting to me. And it seems to be, at least from some recent work, that, again, the way that you can make, you basically, it seems like you're given some capacity, and it's not quite clear why one individual might have, a capacity of some amount, and somebody else might have a slightly higher or slightly lower. But more important than that seems to be how well you use the capacity that you're given, right? So there's this one way in which we often study cognitive capacity is in what's called visual working memory, right? So working memory is just your ability to hold things in mind. And visual working memory is to hold visual things in mind. And like I said, it turns out that on average, the average adult can only hold about 4 things in mind at a time. And the people who do really well, and so if you give somebody a test and you sort of show them a picture and then you take it away and you show them the picture and you ask, did something change? The people who do really well in those tasks, turns out don't have a higher innate capacity, but they have this higher ability to filter out distracting information. Right, so if you tell them, like, what's important in this, what I'm going to test you on is, perhaps the type of tree that was in this scene. People who have higher capacities are better at focusing at the trees, whereas somebody who is a lower capacity is having distracting information, say like a car in the image gets through. So, I mean, this seems like maybe it's something that's trainable.
I think that's very interesting as I think about it. First of all, I hope you never study me because you're going to be very dissatisfied. But I think there's an element of that as I'm thinking about it. I think that's great. So thinking about training, I train my residents and my fellows now as we're starting this whole new field, and we also do standard reconstruction. I have them focus on what's the worst possible thing that could happen to this patient. Put yourself there, and then work backwards. And try to see every potential obstacle that can take you down. How do you avoid this complication? And that's how you need to think. Mm-hmm. So these tasks that you're talking about, in the operating room more than anything, when you have a task that's this important, music, time, it's almost like it's not even, for me, it's like I'm paralyzed in a moment in time and I don't even know what's going on around me. When you're focused, when you're doing something as serious as that. So that's why 36 hours to me, when people ask me, it's very surreal. Because I don't even think that I did it. Yeah. It just went like that. Yeah. Because you're so focused. And you don't even hear what's going on. Obviously, you're cognitive, you're hearing the pulse oximeter and the monitors from the anesthesiologist because that's giving you some cue how the patient's doing and you're listening to important things that are going around you, but you know the specific task at hand and you focus, and it's like everything else. You have always in life, in our positions, we have 10 things that have to be done at once, but we know how to define which are the 5 most important, and you're always working to get back to these other ones, and our goal is always to complete them. But you just got to be willing to be in this state of flux to realize what's important right now, and that needs to be done, and this one has to take a back seat. So you have to always be in that state of flux, especially in surgery with complicated
Yeah, I mean, in
tasks.
neuroscience, this is what we call cognitive flexibility. It's your ability to really change your behavior from moment to moment as your situation or your context is changing.
That task doesn't work so well in my home. But it works very well in a focused task, like especially when you have someone's life in your hands and all these things are happening. The thing about surgery that I really take very serious is that when a patient is under anesthesia, they're 100% vulnerable. So it's really our responsibility to protect this patient and get him out of the operating room safely, because they're defenseless. So, there's so many things going on in our level. It's more than just the material. What's going on there? We got to get this patient out of here, and we have this difficult and complicated task. And when you think about donor and recipients, you have a donor whose family is grieving. They just lost a loved one. They're in a difficult time, and we have to be able to work in that environment and be with these individuals that are in a very difficult time in their life and almost turn that off and get to the task at hand and complete this, because now we have another patient that we have to get out of the operating room. So all these definitions that you're providing are true, and they provide clarity.
Yeah, I mean, and I think it's, so, I mean, there is this question of sort of innateness, and there's this push. So in neuroscience, I guess because in reality is really sort of a study of the self, has, to me at least, is very attractive just on its own. But it has lots of implications for how we sort of interact with the rest of the world. So there's, about a decade ago, there's this real push into neuroeconomics. So it was how do we apply decision-making and how the brain makes decisions to economic theory. And I think that was sort of the first step in where we're beginning to take our knowledge about the brain and make it more practical and applied. And so I'm curious, as we move forward and when we look into medical training, we look into, how do we approach a really complex problem like a face transplant surgery? Can we take some of the knowledge that we know and imbue it? I mean, it sounds like it's not necessarily, you weren't trained that, if you're going to do this really complex surgery, you need to break it down into small pieces. You need to only think about 4 or 5 things at a time. And I'm wondering, do you see a future in sort of bringing this
Sure, it's
stuff in?
challenging. You ask important questions. If you look at surgery, there are some surgeons that are very classical. They do the same operation, they do the same procedure, they do the same thing over and over, and they're perfected. The beauty about what we do in plastic surgery, we're constantly innovating, not only to define a field, but we're presented with so many problems that we have to really think on our feet a lot. It's devastating problems, traumatic, oncologic, congenital issues. A lot of times you don't really have the time to plan and sequence everything out, so we have the ability to really think on our feet pretty fast. But we do have to pay attention to classical conditioning or training of surgery. You cannot veer away from those basic principles, but you have to evolve. So as I think about the task at hand, I don't think we're going to be doing hundreds of face transplants. That's not where this is going. If you think about the lunar space program, who thought that was going to take off? If you step back for a minute, the first kidney transplant occurred in 1954. That was done by a gentleman by the name of Joseph Murray. I had an opportunity to meet him. He's a plastic surgeon. At that point, the field of transplantation was being defined by plastic surgery. And the chief of surgery up in the Harvard program told him, I don't think this transplant business is going to take off. Why don't you go focus on something else? But the reality is that the spin-off of, for example, the face transplant, the amount of discovery that has come from the one patient that we've done is going to be enormous for the medical field in many ways. So every time we do one of these procedures, not only do we help an individual, we help shape the future of many fields of medicine. Sort of like the moonshot, I've defined many applications that we use today, but we're not going to do a lot of these. We hope that we can tie in transplantation with tissue regeneration, and we can ideally grow body parts. But we have to keep at it, because as we keep at this field, we're going to define opportunities. We're helping patients in the meantime. And if we look at the Time magazine piece where the nude mouse came out on the front cover with the ear, if we look at that, that occurred greater than 30 years ago. We really haven't moved forward. That's tissue regeneration. So right now, tissue transplantation is on the forefront, but I think these two fields of tissue regeneration and transplantation are going to come together, and we're going to be able to define what's going to happen next with organ regeneration. But we got to keep at this. There are a number of fields. Liver transplantation, when you talk to Tom Starzl, his first 10 patients died. And he felt that this is not going anywhere. And look at today, liver transplantation happens at every hospital in this nation, in this world. But I think we just got to keep at it. We don't know the direction that we're headed, but we do identify key people. I identify key individuals that I want to train that feel can change, provide a paradigm shift in facial reconstruction in key centers throughout the U.S., and we have to define these teams. It's not going to be for everyone. And you have to think very fast on your feet, because when you're in these environments, you got to be able to move quickly.
Yeah, I mean, I think I just can't imagine having to organize a team of 150. I have 10 people in my lab, and it's often just a mess, a disaster.
Well, it's like a party, right? You invite 10 people, and 10 people invite more. Before you know, you have 150 people.
So you didn't even know everybody's name?
You're like, where did all these people come from? I only have a 6-pack of beer here. But the reality is that every time you bring expertise together, you have to have the ability to welcome thought process from individuals that are leaders in their field. And when I bring on a psychiatrist, the psychiatrist tells me, I have a great clinical psychologist that could provide help. You bring on the clinical psychologist, and he or she tells you, I have a great social worker that can really give you an idea of what the community foundation will be like for this individual when he leaves the hospital. And that's how you build this team. And we have to think that it's beyond surgery. it's greater than just a surgical procedure. It's what happens beforehand, the screening process. So we have what's called the participant selection committee. I have a group of about this room that helps me decide, is this patient worthy of moving forward? Because I cannot trust myself. I need checks and balances. We all need them.
Right.
So I need experts around me to tell me, do we think this patient's the right one to move forward? And that's how we decide. So all these members not only help me make the decision for this patient, but also help me take care of this patient. And we have to support this patient and their family, because we don't know how long this is going to last.
Yeah, I mean, to bring this back into sort of this limited capacity, I think this is one way in which you can deal with a problem that is very complex, is by having people whose job it is to maintain or monitor sort of subtasks.
Sure.
So,
So you bring these 150 people together for this one event. And it's like the party, who's going to be at the end of the cleanup crew, right? And then once you get through this major event, then there are going to be some key players that stay connected with this individual. Immunologist checking the medications. The transplant expert helping me design what's going on with rejection. The pathologist who helps me look at those biopsies that where we define we give medication. The psychosocial team is a huge component of that. Medical ethicists helping me decide, are we going in the right direction? What are the things that how do we move forward? We need expertise in providing additional support and information to Department of Defense. What's the right mechanism for our soldiers if they're faced with this environment? Not only soldiers, but also servicemen and women, police officers, firemen and women. So it's a big picture.
yeah, I mean, I guess I'd also be curious, does the donor's family ever meet the recipient?
So the donation process is a very interesting process. First and foremost, Arthur Kaplan, who's a wonderful ethicist working with me at NYU, a couple of things that you have to keep in mind. When your driver's license, when you put organ donor on your driver's license, it's not guaranteed that your organs will be procured and donated. At the end of the day, your family decides whether you want to give up those organs or not. It's a very transparent process. Surgeons are not involved, which is a good process. We are not involved in talking to donor families, and it's the right way. It should be, because that's their decision. But at the end of the day, although you may want to give up all your organs, your family at the end can say, we don't want them to give the organs. So you can stop that. So it's a little bit of a consent issue that we have to define. We never meet the families. Commonly, the donor and the recipient families don't meet each other. But on occasion, they want to meet each other. We're very careful with this because we don't want to be in a situation that if the donor family knows the recipient family, that the donor family can go to the recipient family and say, we gave you this organ, so we need something in return. So we try to keep that process separate.
Yeah, I'd be more interested in sort of the psychological impact of seeing your husband's face on somebody else.
Correct. The other question you have to keep in mind, does the recipient family really want to meet a donor family? Because you're adding another level of psychological complexity. But the way we deal with this process, for example, if there's going to be a media blitz about a patient, we provide information to the donor family that this patient is going to come out in the news, and I want to make sure that they understand that this is going to happen to prepare them. We always keep them informed. I cannot write a letter to a donor family, but I write the letter through the organ donation organization to send the letter to that family to prepare them. And at some point, the donor family can request from the organ donor program to want to meet that family. And if they agree, they can meet. And in our case, the families did meet. It was pretty emotional.
Yeah, I can imagine.
And we also did a special event for this family because of this one patient. Not only was Richard's life changed, giving him a new face, but 5 other families' lives were changed because 5 other organs were transplanted on a 72-hour event. So we kept going, and other patients kept receiving organs from this patient. Heart, lungs, kidneys, pancreas, and all this kept going. But all these families came together to thank this incredibly generous family for these great gifts. So that was one occasion where they all got to meet the donor family.
Yeah, I mean, I can imagine. I mean, there's going to be media outlets. You're going to see this face. It's going to be in the newspapers. I mean,
Sure.
Do you provide support for the donors to deal with that? Yeah.
Yeah, so that's all done through the Organ Donor Network. They provide support for families, but you're right, the question is how much support is enough for that?
I mean, from a neuroscience perspective, faces are an incredibly salient thing. I mean, there are entire brain regions that seem to be dedicated to doing nothing but processing faces. Right? It's how we communicate, it's how we recognize. So it's a really important part of not only perceiving our sense of self, but also perceiving others.
You're bringing up a great point, Tim. When you think about the face, our face is represented in a portion of our brain, in the cerebral cortex. When we do functional MRIs, it's a really detailed MRI of a patient with facial disfigurement, and we have them do tasks, repeated smiling, repeated tasks. The portion of the brain related to that specific task doesn't, for lack of a better word, doesn't really light up normally in an MRI. What we're seeing now in our patient that received a new face, this part of the brain that was not active now is becoming active. Which is fascinating, how this all starts happening. You know, and he's integrating this new face into his brain, which was completely gone. Very fascinating. It's a very good question, but the answer is no.
Okay.
But to look at it, fast forward, if you go to Richard's home, or you go to the donor's home, to me it's very fascinating. I've been in both of their homes. They have pictures of both of them in both homes next to each other. But they don't have the opportunity to see the face beforehand. So a couple of things, as we start training now, as we're training now here, our team at NYU, I start getting this team for these operations. We start doing these rehearsals for a large number of hours. And I also have my team start getting ready for endurance. So we have to train physically. So we have to exercise and really be as best conditioned for this marathon. So there's a combination of emotional strength, physical strength, and also the ability to tackle this problem. We're pretty well trained. At the beginning, we are a little weak. I will tell you, when we start doing the rehearsals, you could see that we're pooped. When we finish this 12-hour event and we're all driving home, by the time we get home, we collapse. Because it's not so much the physical, it's the mental thought process, thinking about everything. It's almost like the most intense crossword puzzle for 18 hours. It's what you're thinking, very, very concentrated. So we're training that way. And I know when we're ready to move forward. So there are times we do take a break. The break usually you use the restroom, and you get a little coffee, grab a quick meal. It's very short, but that's enough. You also relax as we're doing tag teams. So, for example, I'll be a little bit descriptive. If I'm working on the right side of the neck and I'm really elevating all these tissues, by the time I finish that step, my co-surgeon starts working on the left side, although I'm very attentive watching, my heart rate can go down a little bit. So that's sort of my interval, as if you like spinning, so you're going down, so you relax, and then when he's done, then I come up, then it's my climb again. So you go through these intervals of peaking and relaxing, and you keep climbing every time, and that's how you do it. And once we're getting to a point that we're feeling comfortable, we could take a quick break, get a quick cup of coffee, use the restroom, and then go back in. And with that, I think that provides at least me enough relaxation. In the team, I provide a lot more relaxation for all of them because my team is relatively young, and I need to ensure that they can endure the process. You also have to keep in mind it's more than 36 hours.
I think the reality is that there are many different types of downtime, right? And I think there's being on task and really being focused, and this is something that's really driven by particular brain regions, in particular the frontal cortex, or what is sitting behind your forehead, is thought to be very active whenever you're trying to you focus on a task, right? When you step away from that, it's going to allow you to sort of enter into other types of brain states. There are different ways, again, different stages in which you can be sort of conscious but tuned out. And then there's, of course, unconscious states like sleep. Right? And sleep is really actually an incredibly important brain state. What it's doing is it's allowing for all of the noise that's been sort of accumulated over the day that is sort of changed your brain in different ways. Chemically is one way, but also how you sort of the neurons are wired together is changing over the day as you sort of get tired, and this is sort of allowing it to reset. And so I think this is a big issue as you start to think about, well, can you actually maintain proper vigilance over 36 hours? I think the answer is no.
I agree.
You get very large changes in brain activity over this period. I mean, if you go without sleep for too many days, you die.
Sure.
Right. So it's usually, it depends, but somewhere between 3 and 7 days, and it becomes something that your body just will shut down. And so
I will tell you this: as we were getting close to the end, when I was feeling pretty comfortable, the face was perfused, and we were just doing a little touch-up. The moment you sit down in a chair like this, you definitely start going. So you cannot be too comfortable.
Right.
After we finished that operation, I had to work on a very important person in D.C., close to where you lived, who had undergone chemotherapy. And now was his time for his resection and my reconstruction. And when I was going from University of Maryland to Johns Hopkins, and I sat in the waiting area after I finished this 36-hour event, and now I have to go to this other case. When I sat there and I relaxed, I really you really start slipping away, like you're almost dreaming awake. But then you sort of get up, you got another task at hand, and you become alert. But that little moment of sort of R&R for 20 minutes is probably enough to get me through. Meditation, prayer, however you define it, moments of sort of introspection is how I like to call it. And I do spend a good amount of time in that. And even when we had a photographer taking photographs of me when I was washing my hands, I really washed my hands for a long time, just thinking about everything and where we needed to be and seeing the end point. And so, yes. So one of my important tasks is to define who are the right people that should be doing this. And I think it's very important that centers, right now I can only provide some direction for what happens in the U.S. What happens outside of the U.S. I don't have control over, but I do try to provide some assistance and guidance. If we look at the majority of those centers, it really should be made of people that have expertise in the face. It's what they do every day. It's what we do every day. It makes us better. It should not be an egocentric pursuit. It should not be pursuit for media capture. It's all about the patient. That's what everything is about. Everything else is not as important. So we want to make sure we control that. It's got to be done at hospitals that really have a strong transplant program and have the infrastructure to make this possible. And if you look at the infrastructure of most of the programs in the U.S., some of them have the capacity to do that, but not long term. So my job is to be an advisor to the Department of Defense, the Surgeon General, if I may, to provide my opinion as to who are the centers that may provide this type of work. And there are a number of them that are trying to provide them, but it's not a one-hit wonder. I look at this as a long-term thing, and that's what I plan to do here.